Awesome. I think we have given it enough time. So I'd like to welcome you all today on December 7th to our conversation with Sandra. She's actually going to be discussing how to treat obesity and coexisting morbidities amongst healthcare. And Sandra is from the Montefiore Hospital out in the Bronx. Is that correct, Sandra? Yes. And we are so happy to have her. So we're just going to get going. We're going to go through introductions, a couple of housekeeping items, and then from there, we'll get into the presentation. In addition, this presentation will be recorded. That way you can share with other health centers or other people that you think would be interested in learning more about BMI and obesity. So first things first is this webinar is supported by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views nor are endorsement by HRSA, HHS, or the federal government. And I believe Sandra as well, she had nothing to disclose prior to starting this presentation. So a couple of slight little collective agreements that I like to give to everybody is, I know that for some folks, it's lunchtime. It's 11, 12 to 2 all across the country. So please don't make somebody's yum. If you'd like to eat, you're more than welcome to stay on camera, or you can get off camera. That's a-okay. Since we do have a fairly small group, you are more than welcome to use the chat and the Q&A, raise your hand, politely interject if you'd like to. That way we can answer the question right then and there. Another thing is we'd like folks to take space, make space. And what this essentially means is be aware of the time you use to be sure that other folks get the chance to participate. And also, when possible, please try to talk about your cases on hand while also not disclosing PPI of your prior participants. That would be appreciated. We really want to respect the privacy of anybody we talk about here. Yes. So let's do our icebreakers and our introduction. And I'm just going to start off by introducing myself. My name is Hugo Aguas, and I am a research associate here with the National Healthcare for the Homeless Council. I have been here for about a little over a year, and my work has currently been focusing on SDOH, BMI, and COVID-19. I am currently based out of Los Angeles. And our question for today is, what gift would you like this holiday season? And I recently was gifted an espresso machine by my partner. So I would say I would really like a really good coffee, maybe a $20 bag for Christmas. That sounds great. But with that, I'll introduce it out to Sandra.
Okay, thank you. And hi, everyone. I'm happy to be here today, even though it's a small group. I like it that way because then hopefully we can make it a little bit more conversational and we can discuss a couple of things even better. So as Hugo was saying, I'm Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Hospital. My experience basically comes mostly from the Bronx, where I was working in the South Bronx for the past 15 years. I've been 2 years at NIAC, basically applying everything that we've been working in, that we've been learning in the South Bronx in community work. And what gift would I should say I'm a registered dietitian by training. I have a master's in public health, which is what dedicates my work to the community. And that's how I get involved with all of these things. What gift would I like this season? I've been asking for a Roomba because I'm tired of mopping and cleaning and vacuuming and every day. So I'm like, I just want that little robot that I see on TV and let's see if it works. So that would make me really happy. So if you guys wanna do that, please send it over. I would not be mad about it.
Thank you, Sandra. That was a good one. And I did launch a poll for folks if they would like to give us their information about what role they're playing. But I see that we have multiple folks on here. We have Sonia, Audrey, and Nelson. Would any of you guys like to introduce yourselves real quick in the chat? Oh, excuse me. Or even if you would like to unmute yourselves, you're more than welcome to. Thank you, Audrey. Glad to have you. Well, I guess with that, we will probably just continue to keep going. And before we do, Sandra, can you tell us a little bit of your background as a registered dietitian out in the Bronx?
Yes, I basically, well, I'm native from Bogota, Colombia, where I went to a school for nutrition. Then I came to New York to do my master's in public health. And then I was lucky enough that as I was doing my internship to graduate and get my license as a dietitian when I went to do my internship at the South Bronx. And then ever since I've been working with obesity and things that are related to obesity, obesity, diabetes, hypertension, cardiovascular disease, and believe it or not, babies, pregnant moms, because I've always seen obesity as a consequence rather than a disease itself. So I started getting involved with pregnant moms and babies doing nutrition, trying to avoid childhood obesity from pregnancy. So, not only that, not only seeing patients who were overweight or obese and had obesity-related comorbidities, but also trying to implement community programs that will help the environment to be healthier for those people who needed to lose some weight. So we created community gardens, food pantries, after school programs. We went to churches and taught diabetes prevention programs, diabetes self-management programs. So we did a lot, and we still do now at a different location. So that's a little bit of that background.
Wonderful, thank you. Well, I'm going to hand it over to you, Sandra, and you let me know when you would like me to keep moving on to the next slide.
Go ahead. Okay, so let's start talking about obesity. And here I'm not going to get into the numbers that much. What I want to direct your eyes to are the colors in this map. So this is a map that shows the prevalence of obesity in 2021 as per the latest CDC report. And what we see here is the darker the red, the more obesity we have. If you look at all these, and I'm moving my mouse now. Oh, can you see my mouse moving? Probably not, right, Hugo? So, no. But you look at the dark red colors, exactly, thank you for doing that. In these states, we have over 40% of obesity, which means almost 1 in 2 people are obese. And I'm not talking overweight, I'm talking obese. And we're gonna get into what the difference is between overweight and obese in a minute. But you know what, there is basically very few states that are green: Colorado, DC, Massachusetts. It's amazing how obesity has progressed, unfortunately, in our country. You can go one more.
Sure, and one thing that I would also like to note is that amongst federally qualified health centers, one of the most treated ailments amongst our homeless population is either going to be cardiovascular disease and obesity, unfortunately, as well as diabetes. But I'm sure we'll get more into it, Sandra.
Mm-hmm. Yes, and to me, it's very interesting to show how obesity changes also by race. So this is what these maps are about. So if you see the non-Hispanic Asian adults are mostly on the green zone, which means less than 20 or so % of people are overweight or obese, right? Hispanic whites, we start seeing a little bit more, Hispanic adults more, but definitely the non-Hispanic Black adults carry on, we can say it like that, a heavy weight, literally. And, you know, this is not as strange because we know that minorities as Hispanics and non-Hispanics Blacks are, you know, are very underserved. They're not privileged. They have issues. They live in communities where there are like food deserts. It's a lot going on, and they might not have also culturally and educationally what it needs to learn to eat healthy. So it's lack of economic means, education, food deserts where they live. You know, there are a lot of neighborhoods where the minorities lives that are not safe. So because of that lack of safety, there is also lack of physical activity because people don't want to go out and wander around in the neighborhood. They don't want to take the stairs on their apartments, you know, a lot of consequences. And we see it right here.
And to add again to that fact is amongst people experiencing homelessness when it comes to not having access to things such as clean water, a cooking area, a stove, refrigeration. You need all of these basic necessities to cook healthier meals. And given that a good portion of the homeless population is either is majority Black, it further entrenches them in a state of poverty and the deprivation of health.
Mm-hmm. Absolutely. That's exactly what it is. It's that poverty, right? Shows right here. And unfortunately, you know, we're talking about obesity, but from my experience in the South Bronx, the poorest congressional district of the United States, you know, we can call obesity, but we can call asthma, cardiovascular disease, heart disease, everything basically that comes with health. So every health factor, we see it there because people just don't have the means to live healthier lives. So here are some obesity facts. 40% of adults aged 20 to 39 years, and about 45 of those 40 to 59 years, and about 43% age 60 and older are obese. But, you know, men and women with higher college degrees or higher education have lower obesity compared with those with less education. Now, if we look at pediatrics, which is an epidemic, and we've been saying it for a couple of years now, at least a decade, children, pediatric obesity is an epidemic. As of 2020, 1 in 3 children are overweight or obese. And the problem with that is not that they look chubby or they can't do gym as the other kids, but the problem is as they turn adults, you know, there are a lot of health consequences for these children. And, you know, even though I know a lot of people and a lot of programs and a lot of organizations that are trying to do something to improve the health of these children, is really hard if we don't also improve the environment where these children live.
Thank you, Sandra. And what are contributing factors to childhood obesity right now?
It's many of them, and it's not different than the same factors for adults. It's lack of education, because you know what, unfortunately, children don't feed themselves, right? Parents feed them. So lack of education of the parents, they don't know what to give them. Parents working 2 and 3 shifts, which means they're not there at home to cook for the children. A few years ago, we did a study trying to identify food choices of the parents for their children. And something that got our attention was that most parents in less privileged neighborhoods, what they do is that they feed their children a lot of fast food. And there is a reason for, well, it's actually a couple of reasons for that, which was very interesting for us to find out from this study. One is that obviously moms sometimes are single moms, and even that they can work 2 and 3 shifts, which gives them no time to cook. So you just pick whatever you can on your way back home to give to your children. You don't cook first because you're starving, you want something quick. And second, your kids are starving, you want to just get home and try to relax a little. There is also not enough money, right, to get a lot of food, like good food, salads, vegetables, vegetarian meals, because they are more expensive than burgers and fries. And another thing is guilt, believe it or not, because parents are working so hard, they're not spending enough time with their children. So it's easier to call their children and say, what do you want to eat? Children usually don't ask for lettuce and carrots, obviously, they ask for fast food. I want pizza, I want burgers, I want McNuggets, whatever. So it's a way for the parents to lessen that guilt of not being with their children, trying to show affection through food that way. Like, okay, I'm gonna give my child what my child wants.
Very good point. Thank you so much. I'll move on to the next slide. And one thing that I'm going to do right here is I'm going to launch a poll for folks, just stating who is measuring BMI at their current location or at their facility.
Yeah, so let's talk about BMI a little bit. Basically, what this chart shows is the different stages of BMI or weight. BMI stands for Body Mass Index, which is a measurement of the weight for the height of each person. So if you're on the green and blue, if you're on the blue, you're underweight. If you're on the green, you're at a healthy weight. If you're on the yellow, you're overweight. Then if you're orange, you're obese. Red is morbidly obese. And we're going to explain this a little bit more. So how do you do this? You basically go on the column that has your current weight and also your height. And the weight that you have for your height is going to put you in one of these colors, right? So for example, for myself, and let's say I'm 120 and I'm 5'4", right? So that will put me under a category. Let me just close the poll here because I cannot really look at the chart that much. Okay, so if I'm 120 and I'm 5'4", right? Unfortunately, the way that this slide was done, usually you see the height on one side and the weight, the height goes vertical and the height goes vertical and the weight goes horizontal. So it's easy for you to plot where you are, and then the color will determine, if you're underweight, healthy, overweight, or obese. The height goes vertical down. Okay, but we see here that people are at least measuring some BMI at their location. That's really, really important. And I could not stress less the importance of measuring BMI for both adults and children, especially if you work in healthcare, because, and we're going to talk about this, although it's not 100% accurate, it gives people an eye opener of where they are with their weight. Because you know what, unfortunately, we live in a society where everybody is so large at this point that when we see ourselves large, we think that's normal. Let me give an example. If, for example, you weigh 180 pounds and you're 5'4", but everyone else in your household weighs over 200 pounds, then you feel that you're slim, not necessarily. So it will take for someone else to tell you that you are overweight or even obese because you don't realize your shape anymore. However, BMI for children is different and it's calculated different than for adults. Why? So for children, we look at the weight and the stature. We don't call it height yet, because especially if you're below 2 years old, you cannot stand up. So we look at the weight and we look at the stature, and we plot it in these charts like the one that you see here. These charts are the growth charts by the CDC. A lot of people, what they say is that, oh no, my child is chubbier, but my child doesn't fit in these graphs, because these graphs, especially when we're talking minorities, they are like, oh no, these charts are made in America and Americans are bigger, white people are bigger. Well, let me tell you something. For these charts are based on the World Health Organization research and calculations, which means children from all over the world have served as subjects to be able to plot these charts. So this includes everyone, smaller children, bigger children, everything. And these are averages. Each one of these lines, which we call percentiles, are averages for all the children of the world. So when somebody sees a child like the one here, that is like underneath the lines and doesn't get in the graph, that's an issue. It doesn't have anything to do with, well, I'm small and the father is small, or I'm big and the father is big. This is a very good way to determine the health weight, let's call it like that, of children. You can go on.
Yes, and in the chat, I also added a link to the CDC's website where you can actually assess BMI by yourself, or maybe if you wanted to just take some hypothetical weights to see where one would stand. Let me keep going.
Okay, so how is BMI determined? I already went into this a little bit. So same thing as they do with the charts. The only thing is that, and we're going to get into that in a minute, there is a classification for the BMI, and the only people who didn't make it to that same classification are Asians. People from Asia definitely have a lower BMI. And when we are dietitians and when we are working with weight, we already know that. So for people from Asia or Asian background, unfortunately, they are overweight at a lower BMI, because that's what the research has found. But basically, it's the same thing. They got a whole bunch of people from all races, colors, heights, weights, everything, and they created averages, and that's how they determined the BMI. And this is what I wanted to get to. So is the BMI always accurate? Not really, and we see the pictures here, for example, like you see these two people to the left, and you see one is 135 pounds, she looks nice, but the other one looks even slimmer, and she weighs more, she weighs 140. And the reason for that is because muscle mass weighs more than fat mass, or adipose tissue, as we call it. And so the more you exercise, the more weight you're gonna put, because you have more muscle. How do we then know, just by the chart, if the BMI is accurate or not? We don't. It's a guide, but you really need to speak to a healthcare provider. Usually it is the doctor or a registered dietitian. And based on what is it that you do, how much you eat, what exercise you usually do, what medications you're taking, all your health background and all of that, we are going to be able to determine if that's the correct weight for you. Because again, it could shift. I always like to use Mike Tyson, if you like boxing, as an example, because it's like, okay, somebody can weigh really like 200 pounds or 300 pounds and not be obese. And you're like, how? Okay, because it's all muscle. And muscle is not a problem. What's a problem is the fat that we have in our bodies. So having a lot of muscle is okay, but having a lot of muscle can deviate your BMI to a higher BMI because your weight is higher and not necessarily you're overweight or obese.
I am also going to put another poll up, and this poll is going to be a little quiz for folks to see where they think what a normal BMI range is. And I'm going to give it a moment there, Sandra, that way folks can answer in the chat.
And we should say there is nothing like a wrong answer. So just pick one so that we can see the polls moving. I just like that.
Okay, so we are going to give it 15 more seconds and 3 people haven't answered yet. All righty, let's see where we ended up.
Mm-hmm. Okay, very good. How many people answered, Hugo?
4 out of, we got 4 responses.
Wow, that's very good. So we got 100%. So everybody knew that. That's great. Okay, so let's keep going.
Everybody gets an A, Sandra.
Yeah, that's great. Okay, so you already know this because you answered correctly. So we know where the cutoffs for BMI is. The only thing that I want to say is one thing is overweight and one thing is obese. And then we have extreme obesity, right? So extreme obesity is where we definitely don't want to get, you know, sometimes, unfortunately, I've been a dietitian for the past 20 years. And sometimes when I get an extremely obese patient, I just think, oh, wow, you know, it's going to be a lot of work. It's going to be a long time before you get to a normal weight. And now we have gastric bypass. So sometimes I'm just like, okay, let's see if it's a good candidate, or he or she is a good candidate. Because it's really, really hard when you're in extreme obesity. You know, your body just gets used to the adipose tissue. The adipose tissue starts replicating, and it's very hard to lose the weight. Best stage to lose weight when you're overweight. When you're a little overweight, there is still a lot that you can do. And even though you still need to work a little hard, it doesn't have to be like super hard. But extremely obese is something, you know, it's something else now. And unfortunately, there are so many people who are extremely obese in the United States. And we're going to get now into what brought us here today. And these are the medical complications of obesity. So I like this little picture because it just basically shows how there are complications basically everywhere. So if you want to look at the graph and then go over that a little, because, you know, I don't like to read exactly from the slides or the graphs. So are you surprised by any of these, or did you know all of them? If you didn't know some or one, just check them here because we're going to concentrate on those then.
I'm going to give it like 20 more seconds. And there you are, Sandra. And for anybody else who is curious about the results, you should be able to see them as well.
Yeah, I'm seeing it. So it's mostly a skin disease and idiopathic intracranial hypertension. Yeah, look at that. So most of the time, definitely we hear about non-alcoholic fatty liver disease, or I remember when we were going over this, Hugo, that you said gynecological abnormalities, and that surprised you a little, right? Or like diseases of the reproductive system. Yeah, but it's basically everywhere, just to and cataracts, exactly. So it's everywhere. It's like, unfortunately, sometimes when I explain obesity to my medical students, I just say obesity, when you get to that point of morbid obesity, the obesity cells, they multiply just like cancer cells, and in cancer, we call it metastasis, right? When the cancer cells start reproducing and invading other organs, but that's exactly how it happens with obesity. But unfortunately, there is that huge taboo around obesity, and we don't like to call people obese. We don't like to say, hey, you're fat. Obviously, that's offensive. It's not like we're gonna go around telling people, hey, you have cancer, So, but it is a disease and it grows just exactly like cancer. So sometimes I like to make that comparison so that we get things into context and we see how dangerous this is. It's not just being fat or chubby. This is definitely a disease, and we see how it can reproduce through basically the whole body and affect different organs. So let's start talking about type 2 diabetes, and we're not going to talk about type 1 because type 1 that is not related to obesity, but type 2 diabetes is, as well as it's related to the environment. It's because we eat too much, we don't exercise enough. There may be a genetic component as well, but basically this type of diabetes can lead to other problems. So it's not just the diabetes, and it doesn't just stay there, because it can also cause heart disease, can cause strokes, kidney disease, eye problems, nerve damage, you name it. And the problem is that now 8 out of 10 people with diabetes are overweight or obese. So we see the link right there and then on how the weight is definitely giving people type 2 diabetes. The good news is that by losing between 5 and 7% of weight, which means, you really don't need to lose that much. Like if you're 200 pounds, you need to lose 10 pounds to 14 pounds to already start seeing an improvement in your health. And if you have type 2 diabetes, we see it with gastric bypass, right? A lot of people are losing the weight and the diabetes is going away. So not that we are curing diabetes, because diabetes, unfortunately, so far until now has no cure. But doing the effort of losing a little bit of weight and managing your weight, you can definitely improve your blood sugars. Then high blood pressure. High blood pressure is also called hypertension, as you might know, right? And same thing, it's like high blood pressure doesn't come alone. It also damages your heart. It also can give you strokes, kidney disease, and eventually death. As a matter of fact, we call it the silent killer, because a lot of people, they can't just have a stroke and die, or they can have a heart attack and die, and we don't know. And what's hypertension? Is the force or the pressure with what blood flows through the blood vessels. So if your blood needs more effort or more pressure to go through the blood vessels, you're also giving more work to the heart, because now the heart has to pump harder in order to be able to move the blood. And that's how it starts being a systemic disease, because, it starts from the veins and vessels, but it also goes to the heart, it goes to the head, it goes everywhere. Also, your eyes, for example, they definitely get affected by high blood pressure. And, we've been talking about heart disease, and obviously, people who are very overweight or obese, they can have a heart attack, they can have heart failure, a sudden cardiac death by what we call the widowmaker. The widowmaker is like a fatal heart attack, angina, an abnormal heart rhythm. And this is as consequence of everything else that we're are discussing here. So it could be caused by a combination of obesity, high blood pressure, diabetes, which we call actually metabolic syndrome. So all these diseases together can definitely stop your heart at any moment. And as a matter of fact, I have patients that are, morbidly obese, and they have all of these, right? They have high cholesterol, they have high blood pressure, they have obesity, type 2 diabetes, and all of that. And I always feel bad in a way, like people look at me looking at larger people, and it's not because I'm criticizing, it's just because, oh my God, these people need help. Like, we need to do something to help these people, because they're just basically, believe me, it doesn't sound nice, I know, but it's like a walking heart attack. It could happen at any time because all the factors are there to kill this person. Then we get into strokes, and unfortunately, it's not very hard to imagine that when a person has everything that we've been talking about, right? Like the diabetes, and the blood is thicker, and you don't exercise much, and your vessels and your veins get even stiffer with time because you don't exercise, you don't move, your heart has to work harder, and all of that. It's easy, unfortunately, it's easy to get a stroke. And it can damage brain tissue. And, the way that I see a stroke is like, a lot of people, if they just died from a stroke, I think it will be easier. But I don't know how you feel. I feel that when you get a stroke and half of your body can get paralyzed, or you're not able to speak or move parts of your body, and now you're completely dependent on someone, hopefully a loved one that loves you back, right? But I've seen a lot of patients like that, and it's very disheartening to know that now you cannot eat by yourself, you cannot walk by yourself, or go to the bathroom by yourself. And it's very hard for the family member who's taking care of this person to help, because if you are so overweight, it's very hard to move you. It's very hard to help you out of bed. Per se, you are already stiff, so you cannot help yourself too much. And now add 200 pounds to that, 300 pounds to that, So it's very hard for families when family members have strokes as well. And always asking, can rehab help regain movement? Yes, absolutely. And most patients that have suffered strokes, they definitely get an evaluation by a physical therapist, and then they go to rehab to try to get all of that again. But unfortunately, it takes time and money, and not everybody can pay a good rehab. Some people have to go live in a home for rehab, so they miss their family, they start feeling isolated, they feel depressed, and some people like to eat more when you feel depressed, so that continues the circle. Or if you're at home, then it's the same thing, because you feel bad for putting your family through this. And some people are patient to take care of patients, but some people aren't. So it can generate a lot of psychosocial problems as well within the family, if not economical, because sometimes you have to pay for someone to help you take care of your family member. Or again, if you go to a facility, it might be expensive. What if it's not covered by insurance? Or what if you don't even have insurance? So it's a lot of things that we need to consider. And sometimes when I'm talking to my patients, I'm like, okay, do you prefer to save money on food? Because instead of eating 2 pizzas, maybe you can start by eating 1. And I don't mean a slice of pizza, I mean pizza, whole pie, because some people eat that. I've had patients that eat 12 eggs in one sitting, It's not 1 or 2, it's 12, the whole box. So that's how I put it for them. I'm like, do you want to save money on food, or do you want to just spend all the money now, and then if you get a stroke or something, you're not going to have money to take care of yourself and your family. So, you know, sometimes, especially I'm going to just talk the way I am with my patients. I'm very honest of what things can happen when you're overweight or obese, because that's just the reality. And it doesn't sound nice and it's harsh, but you know what? If you're told that you have cancer, how can you put that like in sweet words? Or if you're told that you have HIV, how are you going to say that in sweet words? You know, like you cannot sugarcoat things. However, I think that we've been trying to sugarcoat obesity for a long, long, long time. And that's what has led us to where we are right now. It shouldn't be sugarcoated no more. But again, that's my personal opinion. So another thing is sleep apnea, which is a common disorder where you don't breathe regularly while you're sleeping. And, you know, sometimes we hear people like, oh no, he or she, they snore a lot. Well, they do. That means you're probably having some issues of sleep apnea. And that's very dangerous, because sleep apnea is also linked to type 2 diabetes and heart disease. And you feel tired all day. And guess what? When you feel tired all day, you crave carbs. And the more carbs you eat, the more calories you eat, the more sugar you eat, the more type 2 diabetes you're going to have, and the more weight you're going to have. So let's go back to the vicious circle. So that's why treating sleep apnea is crucial. So if some of you are listening over there and you have a partner or someone that sleeps next to you and snores a lot, I think it's time to see a doctor, because it's not a matter of a joke. It could be someone's life in danger. That's how it is. So people can, you know, you feel it's this particular noise. It's not just the snoring, but it's like you stop breathing and all of the sudden it's like you're catching up on your breath. So again, it's a good reason to go to a doctor.
And out of curiosity, Sandra, if you believe somebody is going through this, what can you do to help them in that exact moment?
You know what is interesting? It's nothing, I mean, besides waking them up a little, I usually suggest that they put pillows underneath their back, and instead of sleeping, let's say, on their backs, they sleep more like sitting down, like at a 45-degree angle. Because the problem is, if you're very overweight, you have a lot of weight on your abdominal area, then all that fat ends up putting pressure on top of your lungs if you're sleeping on your back. And you get tired of carrying all that weight with your lungs and moving all that weight with your lungs. And that's why sometimes you stop sleeping. So sleeping at a 45-degree angle helps sometimes, because then, you know, some more of the weight falls more towards your pelvis and not so much right on top of your lungs. Or, you know, also like sleeping on the side or proning. And, you know, proning was a very good thing in COVID, and it still is. And that's the reason why. It's because you're taking all the weight away from your lungs, and your lungs can breathe a lot easier. So either prone or on the side, and never on the back. And please visit a doctor. I think that's the most important thing.
So thank you, Sandra.
And this is the metabolic syndrome that we were talking about a few minutes ago. You know, metabolic syndrome, also called metabolic X. And I always wonder why metabolic, metabolic X syndrome. And I always thought, because it's like the X factor, once you see the X, you're out. You know, that's how I feel about metabolic syndrome as well. So it's a combination of many of the things that we were just talking about before. So it's a combination of high blood pressure, diabetes, too much fat around your waist, or what we call the abdominal obesity, or the apple shape. But it's also the high cholesterol, high bad cholesterol, and low good cholesterol. So And the triglycerides, we see them like that, right there and then. That shows exactly, there is an exercise that I do sometimes with my patients. And when they come to me, I always look at the lipid profile. So the lipid profile is what gives us the triglycerides, the good cholesterol, the bad cholesterol, and all of that. And when I have the results, let's say it's you, but I go like, okay, I know what you eat. You like to eat fast food, you like to eat this, you like to, and I give them the list and they're like, oh my God, how did you know? And I said, because I'm seeing it in your blood. You eat a lot of carbs, your triglycerides go high. You eat a lot of fast food, greasy food, your LDL or bad fat goes out. But if you don't eat healthy, you don't eat enough grains, fiber, good fats like avocado, salmon, olive oil, canola oil, then your HDL, which is the good cholesterol, is gonna go low. So pretty much in a lipid profile, I can determine the diet for someone. And that's kind of, that's very interesting. But then again, all of these combined, you need only 3 of these combined to get metabolic syndrome. And what that really, really means is that you're very close to a heart attack. Like, again, you're a walking heart attack. Fatty liver disease is when you have, this is how it works. Your liver helps to metabolize the fat. So it, whatever we eat in excess, it goes to the liver and the liver tries to make fat out of that and put it in a storage. The problem is when you already don't have any more space for storage, the liver starts trying to store the fat in itself. That's just basically fatty liver. So instead of sending the fat away, it's like, you know what? I ran out of stamps. Let me just keep the letters here. That's basically how it works. And the problem with that is that it's going to damage your liver. It's going to cause cirrhosis or liver failure, which is death of your liver tissue. So very important to take care of your liver as well. What causes the fat liver? Fat. Just as simple as that. If you weigh too much, if you eat too much fat, if you keep eating fat and you don't lose weight, your liver also pays the consequences.
Can the liver by any chance regenerate?
It does, actually. It does. So if they take a piece out of your liver, it will regenerate. But the problem is, if you already have cirrhosis, it doesn't regenerate anymore. It's like basically you only have a scar tissue, and that's dead tissue, and it doesn't regenerate anymore. And you need a certain amount of liver, maybe you can lose a piece of your liver or something like that. But if it's completely cirrhotic, that's it. You cannot really do much more.
Thank you.
Osteoarthritis, of course, because, just imagine you're wearing all that weight on top of your bones, and your bones don't get stronger, or your bones don't get thicker, or your bones don't get better because of the weight. If something, they get worse because, it's like the same sticks are trying to now carry 3 times the weight. So that's the reason why osteoarthritis appears, and because of that extra pressure. And it's a lot of pain, and I know a lot of people who are actually disabled because of the osteoarthritis. And, they can hardly move their hands, their knees. So it's a very invalidating disease as well. Then gallbladder disease is also because gallstones might form, if you have too much cholesterol. And then your gallbladder gets full of these stones and it starts losing its functionality. Gallbladder also helps to metabolize fat. And, if it's too much fat that you have, then your gallbladder just basically starts pooping out as well. And there are imbalances, and you might start feeling like if you eat very little, you already feel full. You might suffer a lot of gas, a little bit of pain, diarrhea here and there, So the good thing with the gallbladder is that it's very symptomatic. You can feel it. And there are some people who actually start eating less and losing a little bit of weight because of the gallbladder symptoms, which is not good. I'm not saying that's the right way to lose the weight, but at least it's not like the high blood pressure that is just a silent killer. The gallbladder will let you know way before you need medical attention. And then some cancers. And I think that this is well known now, that when you're overweight or obese, cancer can appear. And as I was saying before, it's just because obesity on the adipose cells reproduce the same way that cancers do. So this is this other issue, right? That obese people have also chronic inflammation. So that can cause DNA damage. And the fat cells themselves, they can start harming the cells around them. So even if you have good cells, the fat cells can damage those good cells. And that's another reason how cancer can be caused. Kidney disease. Why kidneys? If you have diabetes, for example, you need to clean all that sugar from your body through your kidneys. So basically, kidney disease is the consequence of type 2 diabetes, that is the consequence of obesity and high blood pressure as well. So it's not that fat is going to get into your kidneys, no, but fat is going to create some other damage that eventually is going to end up, that your kidneys are going to end up paying for. That's how it works. In pregnancy, couple of different things. A lot of women during pregnancy, they think that they can eat for two, and then they start eating, not double the portions. They start eating a lot more than usual. And that is because, culturally, we think that we need to eat more when we're pregnant. We only need 300 calories extra, and that's starting in the second trimester for pregnancy and for well baby development. And 300 calories can be something like an apple, a yogurt, and maybe some crackers. Nothing more than that. You don't need to eat 2 breakfasts, 2 lunches, 2 dinners. So there are people who gain over 100 pounds during pregnancy. That's just plain obesity. That's not pregnancy. Pregnancy is anywhere between 15 pounds and 45 pounds. And as a matter of fact, I always suggest my patients to go 15 to 30 max. I don't like anyone be gaining more than 30 pounds, because unfortunately, it's going to be very hard to lose that weight, after pregnancy. So baby fat, sometimes I wonder, is it really baby? Because I feel like it's more like mom's fat, because we eat a lot during pregnancy. And that can cause gestational diabetes that eventually, and most of the time, can turn into type 2 diabetes, and preeclampsia, that is the high blood pressure during pregnancy. And that can be a very serious condition because it can actually, kill the baby, kill the mom. So preeclampsia is definitely something that we need to avoid. Then vaginal deliveries are going to be very hard because the babies are usually larger if the pregnancies are larger. So it's not the same delivering a 7-pound baby, and just think of a 7-pound turkey now that we just finished Thanksgiving, and what an 11-pound turkey looks like, right? Or a 10-pound turkey looks like. So just imagine those moms pushing a 10-pound baby out. So it's going to be very hard. And that's another reason why there are a lot of C-sections when moms gain too much weight. Oh, and not to forget, of course, the emotional and psychological problems that come with obesity. All the bullying, it causes depression, it causes anxiety. Then most of the time, people who are overweight or obese, they like to eat. I love to eat. Who doesn't like to eat? Especially if it's good, we just want more and more. And for a long time, we have already lost that society cue. Like, we don't really know when to stop. Like, when food tastes good, we just want to keep eating and eating. So the more weight we gain, probably the more bullying, but the more depressed, because we don't feel good with ourselves. And we look at ourselves in the mirror and go like, oh, I need to lose this, I need to lose that, look at this here. And then we start criticizing ourselves, putting ourselves down. And then on top of that, somebody approaches you and gives you like a funny look or says something like, oh, you've gained some weight. Oh, forget it. That's it. It's like you just want to like go and cry in a corner. So all of those emotional problems, they also end up in eating disorders, and not necessarily the kind that help you lose weight, but more like binge eating, or eating all the wrong foods, or trying to eat less, but then eating a lot more snacks. It's like the snacking, the perpetual snacking. So obviously, there are a lot of emotional issues that obese people go through. And, kids definitely go through a lot of bullying. That's something worth noting. So, not to finish on a gloomy note, right? So we want to talk about prevention a little bit. So losing 5 to 10% of the weight lowers the risk factors for developing obesity-related diseases. We said that before. That is between 10 and 20 pounds if you weigh 200 pounds. But you know what? The recommendation is losing between 1 and 2 pounds per week. And that can sound just 1 or just 2, yeah, do it. It's very hard. I'm a dietitian. Again, I have over 20 years of experience, and sometimes it takes me months to lose 1 pound. I can gain it in Thanksgiving, and then by the time that I hit Christmas, I still haven't lost it. And then comes Christmas and New Year's, and you gain a few more, and then it could take me a whole year to lose what I gained during the holidays until the next holiday season. So it's not easy. Registered dietitian. Yeah, go ahead.
Oh, I was just going to say that I recently actually read an article in the New York Times that stated between the Christmas and Thanksgiving holiday, Americans are projected to gain about 15 pounds on average. And it is hard to keep doing that yearly and to put your body through that grueling gain and then loss of weight.
I'm going to tell you a little story if we have time. I'll take just a minute. So, I'm a Latina, so we make tamales for the holidays. And it's funny, I like to make tamales all year round. And my mom says, well, but if you make tamales all year round, then you're not going to enjoy them as much as Christmas, for Christmas. And you know what? That's the point. Because if I only eat tamales for Christmas, then I want to eat like 2 and 3. But if I eat them along my year, it's like, okay, Christmas comes and I enjoy them, but I don't need to have 2 and 3. And I think that that's part of the problem. Like, we save some dishes only for the holidays. And of course we want to have so much of it because we're not going to be able to see it until, a year from now. So I don't know. That's part of my solution to this issue. But anyway, a registered dietitian nutritionist can help you lose weight, assess what you're eating, how you're eating it, give you tips on how to eat healthier, make healthier meals. And if you don't know one near you, you can always call your insurance. I'm sure that there is somebody linked to your health insurance. Or you can go to eatright.org and find a registered dietitian by just writing down your address or your zip code. You can see who's in the area who can help you.
And I've also learned that myplate.org, the NIH, diabetes.org, all have great resources on obesity prevention, as well as providing more resources for this.
Yes. You said myplate.org?
Yes.
Or just saying, yeah, myplate.org, definitely. And they give you recipes and everything. So if people want to cook a little bit more, they give you very good recipes as well. So.
Lovely. And there are going to be Sonia's references. I want to thank her so much for today and for giving us that very well detailed overview on the comorbidities of obesity and how it can really start to affect almost every facet of the human body. Thank you so much for that, Sandra.
Of course, no problem. My pleasure. I hope that people who were attending, have learned a little bit something from this presentation.
Yes. So we are also going to be saving the recording that we can post it to our website, as well as a PDF version that will be distributed for further information moving forward and for training purposes, as you can imagine. Our moderator today, Brandon, Brandon will be posting a SurveyMonkey link in the chat for us, where you guys can rate this presentation and give us feedback on it as well. And it will definitely start to guide year 3 of our obesity conversation, as well as our BMI conversations moving forward. If anybody has any questions, I think this would be the perfect moment to ask them away.
And I see that the link with the evaluation is up in the chat.
Mm-hmm. And to find all the resources moving forward, you're more than welcome to go to nhchc.org, National Healthcare for the Homeless Council, the abbreviation. And please feel free to follow us on Twitter, Facebook, and YouTube for more information. We also have our National Institute for Medical Respite, where you can find the latest news on respite care throughout the country. All righty, well, with no questions, Sandra, I guess I'm going to give everybody a little bit of their day back. Thank you all so much for attending today, and I can't wait to see you guys next year as well. Happy holidays and stay safe.
Okay, thank you so much for having me. This was a pleasure.
My pleasure. Thank you, Sandra.
Thank you, Hugo.